So good morning. Thank you very much for coming such an early hour. So after mentioning my conflict of interest, to take me a little more seriously, let's put three aims for today's discussion. The first is to discuss the therapeutic approach of bone disease during menopause. I'll try, as our president said, to be as practical as possible, and being the first presenter, I'd like to give a background for the case presentation that will follow from the other speaker. So customizing menopausal hormonal therapy in bone disease, and I thought that a good way to discuss is this to see how to diagnose bone disease at first. Then I'll try to present menopausal hormone treatment and other therapeutical options. I'll try to do my best in order to customize the management and then try to arrive at some conclusion. So let's kick off. Osteoporosis is, of course, loss of bone, and it can be defined through bone densitometry. So if you are up to -1 standard deviation, or otherwise a T-score of -1, this is considered as normal. If you go further low, up to 2.5, so from -1 to 2.5, this is defined as osteopenia, and from 2.5 and below, this is the definition of osteoporosis. One important thing is, of course, to remember that it's not only the very common, very prevalent postmenopausal osteoporosis, but there are causes of secondary osteoporosis as well. And these are seven different teams of causes of secondary osteoporosis. So medications that we must have under mind, endocrine disease, peptic gastrointestinal disease, hematologic disease, plus some other less common entities. If you want to go from a short list to a long one, we are going to have something like this, so drugs such as glucocorticoids and heparin, endocrine disease, gastrointestinal, and so on. Concerning laboratory evaluation, I would consider more or less this as a basic evaluation, so complete blood count, together with biochemistry, including alkaline phosphatase, calcium corrected with albumin, phosphorus, and 25-hydroxy vitamin D. You may add TSH in this basic test. According to your clinical suspicions of another disease, we have just discussed the cases of secondary osteoporosis, you can prescribe additional tests such as urinary 24-hour urine collection for calcium and creatinine, FSH, LH, estradiol, parathormone, and so on. So after having diagnosed your bone disease, let me discuss the menopausal hormone treatment and other therapeutic options that there are available. In the back of my mind, I would say that the first line approach is lifestyle measures and calcium and vitamin D. And then as second line, we have bisphosphonates, denosumab, and SERMs, selective estrogen receptor modulators. With this, I would add the menopausal hormonal treatment, although it's not indicated for treated bone disease. It can be used as this in case we have certain indication. And then we have teriparatide, being unique in what is the only up to now available osteoanabolic medication. So three lines of this. Let's start with the first one, lifestyle measures, calcium and vitamin D. Mentioning lifestyle measures, I have some couples in my mind. So the first couple is calcium and vitamin D. The second one is diet and exercise. The third one is smoking cessation and avoidance of excess alcohol use. And the fourth couple is counseling on falls prevention. And of course, if it's possible, avoiding drugs that increase bone loss. Now, it's not very easy to have the appropriate amount of calcium. You can see here many sources in order to be practical once again, we need something like 1 gram of calcium per day. So keep in your back of your mind that 1 portion of dairy products, such as milk, contains about the third of it, so 300 milligrams. So you need 3 glasses of milk a day in order to take, of course, all calcium that you need every day. My top 10 for calcium-rich food would be something like this: milk, yogurt, plus the other one that you can see on the slide. The problem is that we are far below the indicated amount of calcium all over the lifespan of a woman and a man as well. So if we say that the adolescent needs something like 1,200 milligrams per day, and the average, the classical 1 gram is for the adult life, the perimenopausal women probably needs a little more, and then the elderly need a little more. As you can see from the slide, we are far behind this. It's only during adolescence, actually, that we may reach the required amount, and you can see the dramatic decrease in calcium intake that we have through the lifespan. So there is a clear need for appropriate calcium intake. In order to put it in one recommendation, I would say that women with inadequate dietary intake should take supplemental elemental calcium, something like doses of 500, so divided doses. We have a discussion today about the possibility of calcification in the arteries. So the total calcium intake, that is diet plus the supplement, to approximate something like more than 1 gram, so something like 1,200 milligrams per day. All these recommendations have been nicely put together in a clinical guide of MS. You can find it for free on the website. The same is true more or less for vitamin D. So there are, on top of the sun, there are very strange sources of vitamin D, such as cod and salmon, and my top 10 list would be something like this. Orange juice actually is a very good source for both calcium and vitamin D. Otherwise, you need fortified food, something such as fortified cereals, in order to have the appropriate amount of vitamin D. Women should ingest a total of at least 800 units a day, and higher dose may be required if we have conditions such as malabsorption. Now, leaving this pair behind to go to diet, sometimes we need special things. For a classical example is celiac disease, a major contributor to osteopenia. So on these grounds, a gluten-free diet may result in improvement in bone mineral density. Another important thing is exercise, and just giving a general advice, exercise is not good enough. The same way you prescribe a medication, you have to prescribe medicine, to prescribe physical exercise, and this is one way of prescription. This is the famous FIT principle. So you have to prescribe the exact frequency, intensity, type, and time. Let's apply it. So FIT, if you are targeting to aerobic exercise in order to improve your cardiovascular function, I would go for 3 to 5 times a day. So this is the frequency. The intent, something like 70–80% of maximum heart rate according to your age. The time, something like half an hour a day, progressive if possible, and the type, large muscle group. But of course, there are different types of exercises. If you aim at flexibility, muscle endurance, muscle strength, body composition, and so on. Now, what about osteoporosis that we have discussed today? Women with osteoporosis should exercise for at least 30 minutes every other day, 3 times per week. A variety of exercise types are beneficial: resistance training with elastic bands, jogging, jumping, walking, actually exercising with big muscle group has been proved, as you can see here, the evidence from the Cochrane systematic review, to be effective. Actually, and this is from Cochrane, the most effective type of exercise in order to increase bone mineral density and the femoral neck is non-weight bearing high force exercise. And if you want to increase BMD in the lumbar spine, you have to follow a combined program, mixture of more than one exercise type. So prescription of exercise, and the physician has to be familiarized with this. Smoke cessation, of course. It's not only that smoking 20 cigarettes a day, one pack, has been associated with a 5 to 10% reduction in bone density, but actually smoking tackles the beneficial effects of menopausal hormonal treatment, most possibly by acceleration of estrogen metabolism. So this is the way we want to leave this away. So leaving behind lifestyle measures and calcium, we go to the 1, 2, 3, 4, 5 different types of medication we want, and I'd like just to give you one slide for each for the mechanism of action. Of course, bisphosphonates are incorporated into the bone, so this results in an inhibition of osteoclast function, and the final result is apoptosis. The bone formation is ongoing, so you have a net benefit there, and this is the way the bisphosphonates are working. Denosumab has completely different action, so the rank ligand is actually the crosstalk substance between osteoblast and osteoclast, and denosumab does exactly this, so it binds to rankle, so it interrupts this connection, this crosstalk, and the overall result is an inhibition in osteoclast formation, activity, and survival. A very strange and nice pathophysiology mechanism has to do with SERM, actually. You can see the estrogen receptor, and according to each individual SERM, this can act as an agonist or an antagonist. So if the SERM is connected to the receptor, its shape, it changes, and it makes them probe actually to get together with suppressor or agonists of coagonists of the estrogen receptor. So you can see in the first example that we have a classic paradigm of an antagonist, the change shape, it binds with a repressor, and you have the true action of an antagonist, no signal transduction from there. On the last line of the slide, you can see exactly the opposite, so an agonist, and the result here is a fully functional combination. Of course, you can have everything in the middle according to the stereotactic structure of the estrogen receptor. Estrogens, they act on all 3 types of bone cells, so on osteocyte and especially on osteoblasts. They reduce apoptosis of the osteoblast, and they maintain bone formation. And on the other hand, you have an increase of apoptosis of osteoclasts, having as endpoint a decrease in bone resorption. Have in mind that estrogen have a precursor that is androgen, and both androgen and estrogen act actually on bone, androgen mainly by inhibiting osteoclasts, and estrogen doing the opposite. And finally, teriparatide has to do actually with osteoblasts, so it enhances all the way from the mesenchymal stem cells up to the mature osteoblast, so it induces the production of RANX2, it increases the number of mature osteoblasts, it decreases their apoptosis, it transforms the lining cells of the bone into mature osteoblasts, and of course, it reduces sclerostin, which is an inhibitor of bone formation. So 5 different ways, 5 different mechanisms by which teriparatide is acting as an osteoanabolic medication. If I would want to put all this medication in just one slide, this is the result. So a biphosphonate that incorporates into the bone, denosumab that dearranges the linkage between the osteoblast and osteoclast, estrogens and SERMs that they act both on osteoblast and on osteoclast, and the teriparatides that it acts directly to the osteoblast or indirectly through the Wnt anabolic pathway. So these are the mechanisms. So we have our medication, discuss about diet, calcium, all the different medication. Now try to do some customization, how we are going to use this drug in order to treat our patient. I would like to have in mind some consideration. The first one is that the endpoint, of course, is fracture. What we want to do with anti-osteoporotic medication is just to reduce fracture, especially the three main type of postmenopausal fracture, that is the vertebrate, the hip one, and the non-vertebral one, like the wrist fracture. You can calculate the wrist fracture through this practical tool. You know, it's the fracture tool. This is the Greek version, and this is the English one. So 12 rather easy to answer questions. It's available free on the network. And this is a completed one that gives us a result, good results, a possibility of major osteoporotic fracture of 3.8, a hip fracture of just 2.2. It's very practical. You can have it on your iPhone or on your smartphone and use it from there. Another important thing is it's a very good predictor of the bone loss is age, actually. So in the early age, I would say up to 70, the baseline possibility of a fracture, in this case a hip fracture, is low. And then you can see an exponential increase in the fracture rate. So if you use a drug, keep in mind that the number needed to treat, actually, which is the ultimate measure of effectiveness of one drug, is very high. You have to treat a lot in these ages in order to prevent one fracture, and quite the opposite is true for ages over 70. You have to treat a low number of patients in order to prevent one event, in this case, one hip fracture. So keep in mind the age. Now, when we are going to abandon, not to abandon actually, but to expand our treatment with lifestyle measures and go to the drugs, I would say that there are three rough indications. One has to do with established osteoporosis, so fracture. So if you have a history of hip or vertebral fracture, you have to treat. The second one is the classical definition of osteoporosis, a T-score of less than minus 2.5. You could consider starting a medication. And the third one is the osteopenia range from minus 1 to 2.5. If, according to the FRAX, you have high possibilities of hip fracture, defined as more than 3% over a duration of 10 years, or up to 20% for any major osteoporosis fracture. So three main indications for pharmacologic intervention. What I'd like to know from every medication is its efficacy and its safety. So these are the medications we have discussed so far. And of course, all of them have established their efficacy on vertebral fracture. Otherwise, they would not be considered as anti-osteoporotic medication. Nevertheless, this is not true for non-vertebral fracture. As you can see, there are some red X's, so no established efficacy, and some yellow one with intermediate efficacy. So the efficacy for non-vertebral fracture remains for the bisphosphonates, for the denosumab, HRT, and teriparatide. And concerning the most difficult, because the less prevalent endpoint, the hip fracture, we lose teriparatide. There is no evidence for efficacy in hip fracture. Of course, we have to keep this in mind when we customize therapy. If we suspected that we have high risk fracture possibility for a specific site, that is the wrist or the hip or the vertebral spine, we have to consider a medication that is effective exactly for this one. And as we've discussed, knowing that it's effective is not good. I would like to measure the magnitude of efficacy. And roughly, this is rough Stavrula, we have to make a meta-analysis on this actually. So the number needed to treat, this is the mean from all this medication in order to prevent a vertebral fracture, is something like 75 women for 2 years. So you have to treat with this medication a woman for 2 years, 75 women, in order to prevent one vertebral fracture. And concerning non-vertebral and hip fracture, this goes down to 55 women for 2 years. So they are not extremely effective medication, although this is about the same in other medications such as statins or antihypertensive medication. Another important thing, of course, is safety, adverse effects, and you can see on the first row our medication, the specific adverse effects, and the evidence, if the evidence is strong or moderate or low for this, and the magnitude of this effect. Nevertheless, I'm never happy with the relative magnitude of effects. I mean, the possibility, the odds ratio or the risk ratio may go 2 times up or 3 times up, but what I want is the baseline probability in order to calculate the absolute ratio. And I think the real picture comes from here. So biphosphonates, I was impressed actually from the literature saying that we consider it common, the mild upper gastrointestinal symptoms for a biphosphonate could be, according to different references, from 10%, 100 to 1,000, up to 95%. So it has to do actually with how sensitive I think the researcher is and in order to recording this complication. In any case, we would agree that the atypical fractures and the jaw osteonecrosis are very rare complications. Actually, we discussed yesterday that they affect specific type of patient, mainly oncologic patient. Now, concerning zoledronic acid, you can see how the relative magnitude may misleading. So the odds ratio for hypocalcemia and influenza-like symptom is almost the same, odds ratio of 6 or 7, but the absolute rate is quite different. The possibility of hypocalcemia is something like 10%, whereas the influenza-like symptom is something like 80%, 800 out of 1,000 people. The possibility of denosumab to have infection or inflammatory reaction actually is not very high. You need 100 to treat 118 patients in order to have one such event, so number needed to harm 118. Concerning raloxifene, we all know about the hot flashes, but they are not very common actually. You can see the absolute magnitude. HRT, we're going to discuss for this, and teriparatide, which is its adverse effects, headache and hypercalcemia are quite common, as you can see there. So you have a rough idea what to expect with medication, one again expressed as absolute magnitude. Another thing is the sequential therapy. So if we start something, can we stop it? And we have some evidence, I would say, just for biphosphonate. Emas, once again, published a position statement with Panagiotis Anagnostis and Stavroula Pascu. We saw some hints of it yesterday. And in order to make a long story short, I would say that you would consider discontinuation of biphosphonate in all patients who have been treated for more than 5 years, especially with these biphosphonates, the more common one. You remember, discuss it, it has been incorporated into the bone and it stays there. So from a pathophysiological point of view, it looks reasonable to discontinue. But it's not only this, there are epidemiological data actually show that the preventive effect stays there. So you would consider, we analyze the evidence, that you can, the duration of drug holidays could be 1 to 2 years for isendronate, 3 to 5 years for alendronate, and 3 to 6 years for zoledronic acid. After this time, you have to reassess the patient. Of course, if you have a new fracture or a fracture risk has been increased, or the T-score went below minus 2.1, you have to reconsider this medication. Another thing that you have to in mind that this medication do not act only on bone, but on other tissues as well, and I mean only I put here only the genital tissues, the reproductive system. So the biphosphonate are of course very neutral. They have they are targeted on bone, they have an effect on bone, and they are neutral to all others. This is not true with HRT, that has additional benefits, as of course the treatment of flashes and vaginal symptoms, On the other hand, we have the increase, the combination of the breast disease. Quite the opposite is the picture in SERM. SERM is considered protective, even a treatment for breast disease. On the other hand, you may have an exacerbation of flashes, but we saw the absolute magnitude, the absolute effect just before. You can even have a combination of these two. Another important thing is that in real life, your patient has not only osteoporosis. We do not have just to consider the other tissues, but it happens to have other diseases as well. And another very common disease is diabetes. Although there are some conflicting evidence if patients with diabetes has reduced normal or increased BMD, it has that they have decreased in a meta-analysis, you can see the reference there. The relative risk for hip fracture was something like 3 times more for men and 2 times more for women. So it seems that diabetes has a detrimental effect on bone. If this is true, then, and it's very common that we treat these diseases together, we have to know the effect of the one type of medication to the other disease. So the effect of anti-diabetic medication to bone disease and the opposite one. And this is a very good idea of Stavroula that was published 3 months ago in the JCM. So that was it. And once again, just to give you the evidence, if you have diabetes type 2 and you are taking metformin, these are rather good news for your bones. You can see that the fracture rate, I'm leaving all the other together, the markers, I'm going directly to fracture, is getting down. The same is true for sulfonylureas, all drugs. The possibility of fracture is rather reduced if you use this medication. Quite the opposite is the picture with glitazones. You can see in every reference that the possibility of fracture goes up, especially in postmenopausal women. The effect of DTP4 inhibitors are rather neutral. The effect of GLP-1 analogs is rather neutral, although it depends on the medication. And of course, the effect of the new type of medication, SGLT2, is rather not good. I put it in red color. Insulin does not have a beneficial effect on bone as well, as it increases the possibility of fracture. Now, quite the opposite. If I have osteoporosis and I take an anti-osteoporotic medication, what would be the effect on my diabetes? You can see that biphosphonates, they have an advantage. They decrease the new onset diabetes, whereas the SERMs and the basedoxifene, the SERMs, have rather neutral effects. So in order to put this in one slide, there are some lifestyle modification that would make you good for both diseases, both diabetes and osteoporosis. But if you have both diseases, it's better for the sake of your bone to treat with metformin and sulfonylurea or this neutral medication and try, if possible, to avoid the glitazones and insulin, if it's at all possible. And concerning the opposite, biphosphonate seems to make good things to your bone as well. So in order to put this in a rule of thumb, actually, slide, I would say something like this. There will be many exceptions. This is proposed by Palacios, that the perimenopausal year or the early menopausal year, so let's say it's the 50s, it's time for HRT, or if we have the indication and contraindication we discussed, there may be a time for SERM. Then when you move a decade after, so something like in your 6th decade, it's time for biphosphonate and denosumab. The evidence is for these ages, and then you can keep as a last resort paratherm PTH. Anyways, you can use it just for 2 years according to the indication. So how I would conclude, my aim was to discuss therapeutic approach of bone disease during menopause. I try to be practical and to give a background for the case to follow. What we know about the treatment of postmenopausal osteoporosis, we know about the efficacy. Efficacy is how effective is a drug in ideal condition, in trials if you prefer. And we have some evidence about this, and we have some evidence about the safety. What we do not know is the effectiveness, so how effective is a drug in real-world situation, and we lack evidence in this. I gave you some evidence on comorbidities. We do not know very many things about sequential therapy. We discussed that you could actually give a drug holiday to a biphosphonate, but I am afraid this is not true at all for denosumab, as discussed yesterday with Professor Gliritis. We do not know very many things in integral therapy, and what I'm saying integral therapy is not combination of drugs. We do not use combination of drugs in osteoporosis, but actually an integral therapy with calcium, vitamin T, and lifestyle modification. And of course, we leave behind the male osteoporosis, which is another important thing. Thank you very much for your kind attention.